Good afternoon, everyone. I want to thank the members of this committee, Deputy Commissioner Connolly and your team and providers across Minnesota, advocates and individuals and families who have taken time to be here today. I've also got our House, I just said House, Dr. Liskey, so that's not good. The other body is here, our partners in the whole process, and I've also people that were part of Melissa Wickland's committee are also here as well. We want to thank everybody for being here. And today's hearing is about one thing, and that's ensuring that Minnesota has a provider enrollment and revalidation system that protects program integrity while preserving access to care for the people who depend on it every single day. We all agree on an important principle. Medicaid providers must meet federal and state requirements. Revalidation is not optional. It is an essential safeguard that helps ensure taxpayer dollars are protected and the qualified providers are serving Minnesotans. The question before us today is not whether a revalidation should occur. The question is how it was implemented. Minnesota faced an unprecedented challenge. Federal expectations require the department to complete in a matter of months that usually other states have 2 to 4 years to complete. That created in and itself enormous pressure throughout the system. The department made decisions in response to those federal requirements. Providers are asked to navigate changing guidance, documentation requests, communication challenges, and compressed timelines while continuing to provide care for some of the most vulnerable residents in our state. Some providers succeeded. Many experienced delays, confusion, payment interruptions, and uncertainty about whether they could continue serving the people who rely on them. But let's be clear, behind every delayed application or suspended payment is not simply a provider. There's an older adult that's waiting for home care, a child receiving therapy, a person with a disability depending on daily support, an individual working through substance use recovery. Those are the people at the center of today's discussion. And so I want to make it very clear, members, this hearing is not about assigning blame or scoring political points. It's about understanding what happened, identify what worked, acknowledge what did not, and determine what changes that we need to make moving forward. I think we owe that to providers who acted in good faith. We owe it to the taxpayers who expect accountability. But most importantly, members, we owe it to Minnesotans whose health and independence depend specifically on a stable provider network. And so the purpose of oversight is not simply to identify problems. The purpose of us in this oversight is to improve governance. And I appreciate, Deputy Commissioner, the department's willingness to participate today. And I appreciate the providers who have shared their experiences. Both perspectives are essential if we're going to make informed policy decisions. And members, there is in your packet copies of letters that were sent to us. So I ask everyone participating in today's hearing to approach this discussion with professionalism, respect, and a shared commitment to improving the system. Our responsibility is larger than just this hearing. Our responsibility is to ensure that Minnesota has a Medicaid program that is accountable, transparent, federally compliant, and above all, responsive to the needs of the people it serves. Before we go to you, Deputy Commissioner, I'd ask the Chair, Noor, for comments. Thank you.
Thank you, Mr. Chair and members. It has not been an easy year, to state the least. When we saw what happened, that the requirement for the state from the federal government, when the payment withholding of $515 million on a quarterly basis that was put under the federal law, stating that the state of Minnesota is out of compliance, that requiring that we produce a corrective action plan. Indeed, that is about $2 billion ongoing payment withhold that the threat from the federal government exists. Through that process, the state complied, sent a letter of compliance based on what needs to be done, And that compliance later was accepted. After that exception, I think there were so many other things that happened or transpired after that. On top of the payment withhold, which is a $2 billion, the federal government, again, put a state on a deferral, meaning that the resources that we've already spent, that we're waiting for the bills to be paid, effective the quarter that ended last year, the state of Minnesota was put on a $250 million on a quarterly basis, going back then, to be put on a deferral, meaning that the funds will be deferred. Even recently, there was an addition to that 250, additional $90 million that is being deferred by the federal government. To me, Mr. Chair and members, that is weaponizing Medicaid for those who need the most. It's weaponizing the services that serve 1.5 million Minnesotans. It's putting people at risk. We have seen instances whereby there's a delay of care, there's a delay of services, that it ends up even to death of individuals. We've got a significant challenge. As the chair noted, the revalidation process we were given a 5-month period to do almost 5,600 revalidation of providers. It's not an easy undertaking. And that, to me, is why we're here today. The issues that we're facing is no longer isolated. Providers have been navigating enrollment issues, MPSC, which is the portal system that they use, the background studies, site visits, appeals, billing suspension, and now there's a transition to login MN, which is also complicating the process. Members, I think this requires a more depth discussion and figuring out where we're headed. I talked about the federal government weaponizing Medicaid, and I yet to hear the conclusion to the deferral, the conclusion to the payment withhold from the federal government. And the next steps. We have to put accountability in place, but we also need to be able to understand every services that is being provided, there's a human being. There's a person who's elderly, disabled, a child, a family, that is going to be impacted by the actions that we take or not take at the moment. Yes, there's so many issues and challenges that we would like to do in a different way. Given the circumstances, I think we will let Commissioner Conley, who's before us, to walk us through, and we will have a thorough discussion of where we go from here. Thank you, Mr. Chair.
Mr. Chair.
Senator Abler.
Can you hear me?
We can now, Senator. Yeah.
Okay, thank you. Anyways, thank you for the hearing. I appreciate the premise that you're doing here. I just want to single out again Haley Kolkind, who I think was like the Red Dare coming to the rescue here, and I admire her for her work and appreciate that. And just going forward, Mr. Chair, if there's some things we can do offline that are connected to this, the provider credit update, how that's going. A lot of people are waiting for UMPI numbers for months. The level of withholds, so like some of the ATAM providers and other legacy providers, which are really burdensome. And then finally, if there's somebody can share a contact with me that I can reach out to DHS, I think those can be taken offline, but I think they're just really important too. So, Mr. Chair, I mostly plan to listen today, but thank you for the hearing. I'm grateful.
No, appreciate that. And Senator, we'll have Bryce and David follow up with what you have there. Don Gilman.
Very nice, thank you.
Thank you.
Thank you so much, and thank you, Mr. Chair, for having this meeting today. Again, here we are. We care about you. And again, I do want to just kind of pivot back to our responsibility and focus on what we did after COVID and just loosening things and loosening how people could be eligible, and just the expansion of providers that happened during that time, and what we can do to get back to accountability, and again, ensuring that we have the providers that need to be, especially in rural Minnesota has been impacted the most. We'll hear a lot from them. I'm glad that we're here to do this. It's very hard to not go partisan, and I've heard some of that partisan talk happening here, but with letters from the governor's office and also, in communication with DHS and different folks, we have a shared goal, I hope. And there is some things that need to happen, and I'm excited for some of those questions to be answered today into, our legacy providers and why weren't we pivoting to them first and different things like that, so we can help meet the needs of those most vulnerable. So thank you.
Well said. I think with that, we'll go to Senator Rasmussen, and then thoughts about when we get to you, Commissioner Connolly, then we can figure out if we want to stop in the process to answer questions or wait till the end. I think what we'll do is we'll wait till the end and we'll just get a list of people that have questions for you. So Senator Rasmussen, take us home.
Thank you, Mr. Chair, and I appreciate the opportunity to have this important hearing today on an issue that is concerning and impacting Minnesotans across the state. To me, the fundamental challenge that we keep on coming back to, and we've had this discussion on this committee previously, is that the Department of Human Services is unable or has really struggled to be able to differentiate between a good provider who's providing services that are needed by Minnesotans with disabilities and a provider who's fraudulent and stealing from Minnesota taxpayers. And Minnesotans have an expectation that the Department of Human Services is going to have services for Minnesotans in need, while also protecting their taxpayer dollars from going to criminals, and we can and we must do both. One of the answers that I would really like to have answered here today by the Deputy Commissioner as we go through the presentation is how did we get to such a point, and why wasn't the legislature notified sooner about the issues that the Department of Human Services was having on meeting the revalidation deadline that they had agreed to. They agreed to this deadline before we started session this year, and at least I wasn't notified that there were going to be these major issues with denials until it was days before providers and the state found out that there would be thousands of denials, and in fact, a majority of the providers going through this process were going to be denied and need to appeal if they wish to remain as a provider. So those are some of the questions I'm looking forward to having answered today, and also hope that there'll be clarity on the process going forward to providers and their clients and the Minnesotans that rely on these services, so that we make sure that everyone's getting what they need from the state. Thank you, Mr. Chair.
Thank you, Lead Rasmussen. And I, you and I, I'll be corrected, and it didn't dawn on me until you had said the same thing, Deputy Commissioner. It's actually Interim Commissioner, so sorry about that. Temporary Commissioner. Is it interim or temporary? You just educate me, will you? The floor is yours, Mr. Connolly.
Thank you, Chair Hoffman. Thank you to the members for your opening comments. I think we share much of what was expressed, and it's good to be here in this new role in partnership with you all on these important issues, the dual imperatives that we have with respect to both program integrity, the strongest possible program integrity for our Medicaid program, in addition to making sure that people have access and continuity of care. Those are things that are fundamental to our job. They are dual imperatives, and we know, I think as many of you said, the Medicaid program, among others at the Department of Human Services, they are essential to the health, stability, the well-being of folks to be able to live their fullest, healthiest lives in their homes and communities. And we know it is essential to children, families, people with disabilities, older adults, people with mental health conditions, substance use disorders, many of the folks that you all mentioned. So we know that this program is a foundation for our healthcare system and essential to so many in our state, over 1 million. And so I'm here today at the invitation of Chair Hoffman to provide some opening comments and an update about the revalidation effort. I'll be happy to answer questions at the Chair's direction when we're done with the presentation here. I'll start with just some opening comments and then, of course, a quick briefing with a few slides. And as I think folks have said here, members of the committee, the Chair, that we have revalidated all providers in 13 service lines. And I'll just state plainly the reason for that. The Centers for Medicare and Medicaid Services basically directed us in letters on December 5th and January 6th, at the end of 2025 and early 2026, that this was something that had to happen. It was a cornerstone of what they sought in a corrective action plan from us to address program integrity issues and concerns that they had. Of course, the $2.1 billion withholding was the attachment to this corrective action plan. That is a huge risk for our Medicaid program. It's 10% of the Medicaid program's budget, 1/3 of disability waiver spending alone per year. In addition, as I think the chair and others mentioned, there were additional actions in February with the focused review being announced by the vice president and the CMS administrator, and over $350 million now being deferred as a part of that focused review of claims. And we do believe there's continuing risk for more deferrals in future quarters, just to be forthright with the committee about that. We are being vigilant about that, and of course, watching any communication from CMS. So given these tremendous deferrals, withholdings, risks to our program, we did our best to submit a very comprehensive corrective action plan, of course, with this off-cycle full revalidation of all providers in those 13 services within 5 months. And I'll note to the committee, part of why we agreed to this with CMS is that, again, not only did they state in both those letters, but also the acceptance of the corrective action plan, which I think Chair Knorr noted in March. Deputy Administrator Kim Brandt said, affirming this is the cornerstone of your corrective action plan, confirm that you can get this done. Again, emphasizing that this was something that was of top importance to them in our corrective actions. So we saw this again as a tremendous imperative and something that we had to execute. So that said, as we did this, our intention, our core imperatives were again making sure that we have the strongest possible program integrity for the Medicaid program. The people in our program and the people of Minnesota deserve that. And also making sure that people had continuity of care and access to service. Those are our dual imperatives. Those are core to our job in operating a Medicaid program and providing service to people, and again, being stewards of taxpayer funding. With respect to the work that we did as we did revalidation, the key parts of that were to ensure that we had accurate, up-to-date ownership and leadership information from the organizations, to ensure that there wasn't involvement in other kind of criminal or suspicious activity, or they weren't on exclusion lists. Again, just knowing who's in leadership of an organization to make sure that there aren't bad actors involved with them. And then, of course, quality of service and qualification requirements that are basic to being a Medicaid provider, things such as staffing levels, staffing licensing and qualifications, required trainings in place, and proof of insurance, very basic things that just must be in place, I think, as the chair said in his opening comments. So that was the work that we were engaged in and had to get done. I want to acknowledge, too, I think as many said in their opening comments, this was extraordinary. This was incredibly challenging for the providers. We understand that behind these provider or served by these provider organizations are people, the people of our programs that we have a responsibility to. It was extraordinary also for the people of DHS to execute. Days, nights, weekends, holidays, they really gave it their all. And we tried very hard to do the best and most effective job that we could. That said, we want to acknowledge this has not been perfect. This has not been perfect. We are not perfect as a department. That said, we sought to engage with providers, with legislators, with advocates, proactively creating a variety of different feedback forums, webinars, regular meetings, different types of communication through different media. And again, we stood for, I think, questions in those different meetings. Of course, had different hearings with legislators and sought to be responsive as we received feedback. And certainly we've heard a lot of feedback from you all and from providers, and we have tried to review each of those instances, tracking down what the issues may have been, seeking places where we could adjust and do better. And we will continue to do that. So I'm here today in that spirit. I want to continue to partner with you, the legislature, as well as our provider and advocate community and those in our programs, in the spirit of continuous improvement. After all, that is my job. My job and the work of government, the work of Medicaid, the work of human services is continuous improvement. There is no finish line to program integrity. There is no finish line for doing better for the people we serve and for the people of Minnesota. So I'm here in that spirit today, and I think I'll give a brief kind of presentation here. I'll try to keep this short so we have plenty of time for questions, to just give you an update of where we are in the process, and happy, of course, to stand for questions afterward. So some of this information I already shared. Of course, we had a 5-month effort that concluded, at least in the revalidation piece of this. Of course, appeals are ongoing. That concluded May 31st, and I think as leadership of the committees here stated, 5,583 providers in the 13 service categories were identified for that revalidation. I mentioned the $2 billion and what that represents in terms of a third of disability waiver funding, and 10%, roughly 15% counting the deferrals of overall Medicaid funding for Minnesota. And as I said, this is a critical piece of the corrective action plan at CMS's direction, and we seek to protect this critical funding while maintaining access to service for people. In addition, it's important to note that following what transpired here in Minnesota and the communications and requirements of CMS, other states, all the other states, territories, and the District of Columbia were given 2 years to do what we have done in roughly 5 months. So they have taken this approach, and they have required all states to go through this. Although I will note, again, with a less extraordinary timeline. I will also note that other states have not had the same level of risk applied to their programs financially. There have been other states now that have experienced deferrals, but nothing on the level in terms of the percentage of the program's financing that we have experienced. How we did this work and how we've tried to meet this moment, we started in January with an incident command structure that was designed in the State Emergency Operations Center with Minnesota Homeland Security and emergency management partners. We, under that incident command, brought in more than 100 staff from across the enterprise. I want to issue a thank you to all the staff that answered the call from across Minnesota state government to help us get this done. Over the past 5 months, we made over nearly 10,000 calls to providers, 4,000 from our provider call center. And again, as I said, we sought to engage providers weekly in roundtables, continuity of care coordination meetings with counties, tribal nations and managed care organizations, and have directly engaged now with members themselves with resources from the legislature. So I'll thank the committee and legislators for that as well. In terms of the results of this effort, 2,000 roughly were revalidated successfully. That's about 38%. 62% received disenrollment notices, and the majority of that 3,400 are going through the appeals process now, though not all. And I'll get to that data point in a second. I want to say that of those, I think there's been much said about the disenrollment notices and what it means. This is not necessarily an indication of fraud. I think this is, again, an indication of having the documentation that is necessary, the credentials evidenced in place and accurate, current, and complete for Medicaid provider enrollment, to be specific. In terms of the appeals, this is the phase of the process we are in now. Providers have 60 days to respond to that disenrollment notice and to initiate an appeal. We're encouraging them to do so within 7 days, however. 2,472, these data are just a couple of days old, but they're fairly current. The numbers are probably a bit different as of right now, midday on Thursday, or today is Wednesday, excuse me, July 1st. There are 2,151 appeals in process. The number here is 321 appeals completed. I'm aware that's actually increased some, so they have adjusted some at this point. And I'm aware that this number is now slightly under 600 who have not appealed. So these numbers continue to move really by the hour. And 353, their appeal window has closed, meaning they will be disenrolled. I think I described these pieces previously here in the presentation. So we're encouraging directly providers to appeal. We're outreaching to them, paying particular attention to residential providers, mindful that having folks housing associated with the treatment that they are providing, their shelter associated with treatment is very important. In addition, we're I'll be forthright, we are continuing to iteratively work with providers on getting the documentation right, but we continue to lean into that to try to help them understand what the issues are, the discrepancies or inaccuracies, the incompleteness, and help them get that right to the extent possible. I'll note that if we can't get there, and again, we'll continue to work through this as long as providers are responsive to us. Within 30 days, we'll continue to work through this process. We will refer for a contested case hearing if we can't rectify that issue through technical assistance and engagement with the providers. To mitigate service recipient impact, you know what, I might just move to the next slide because there's more detail about this piece in terms of continuity of care. We're working with lead agencies, so tribal nations, counties, and managed care organizations, again, if we sense there's a possibility of an interruption in service. So we are meeting weekly with these entities to help them understand which providers have appealed, which haven't, and the members associated with those providers, so there can be proactive outreach to the providers and to the people that they serve if there is a potential disruption in service, if there's a chance, again, a provider doesn't make it through the appeal process. We're also now, and again, I want to thank the legislature for these resources, expanding our ability to work directly with enrollees. If they're not enrolled in a managed care plan, if they don't have a county or a tribal nation providing case management, for example, waiver case management, we're reaching out directly to indicate when folks may have a service disruption and help them find a new provider and preserve continuity of care. I think the other thing that's important here is connecting folks to income support where needed as well, given the vulnerabilities that folks are facing and to pay for housing costs in particular. A little more here on the new continuity of care law. Again, thanks for the support. This is really outlining all of the different pieces that we're engaged in implementing now, making sure that folks, again, have that support. And I'll really focus on the third point here on this slide, which is that we want to make sure for folks, again, who have a housing risk, that housing support is leveraged more assertively to preserve housing if their treatment provider is disrupted and there's a housing provision related to their treatment, so that folks have that, and providing, of course, grant assistance to providers in those impacted benefits. So with that, I think without taking more time, I will stop, and I'm glad to stand for questions.
No, yeah, I can see, there's a couple of things, Commissioner. I looked at the numbers and I was looking down the table, and it's almost in the appeals numbers, you almost had 1,000 people. And my first thought is, what's the department, 1,000 providers, what's the department doing to assure the continuity of care? And if you look back all season, that's all I kept talking about was continuity of care. And so what's in place for that? And we'll hear from providers. We have 11 people that have signed up to testify, and you'll hear from providers today that the system is not going as smooth as it should be. And so I think it'll be good for that, which then leads me to this next statement. Leadership this year went off into the corner, and they all decided to cut $300 million from human services. That's $300 million. That's program integrity. That's stuff that matters to people, right? And so it bothers me to hear about this weight that has been, added regarding extra work, and not that extra work, but time that it takes, and that we're hearing from providers that the response has not been reasonable, right? And I was with two providers yesterday who are experiencing the same issue. So tell me before we go, the Zoom user is actually Senator Glenn Gruenhagen. Before I go to you, Glenn, I just want him to follow up with what's in place to assure continuity of care.
So thank you, Chair. A couple of things I'll highlight. I think first is we understand that given the numbers I presented, having all of the providers who were not revalidated, cut off from payment would have been highly disruptive. We can't afford that level of disruption. And at the same time, we need to make sure that folks, I think as you expressed, have the right documentation, have those basic requirements met in terms of compliance and program integrity for the Medicaid program. So the first thing, of course, was outreaching to providers to let them know that upon appeal, if they appeal, and that's why we continue to reach out to those that haven't, they can resume their ability to bill. And we fairly quickly, within a week or two, were able to restore the ability of providers to bill. We are aware that there are still some instances of providers, communicating us with difficulty with that. And as they arise, we are, I think, following up as we receive that information. But that was the first step to help providers continue to provide service. And then in addition, we had the weekly meetings with counties, tribal nations, MCOs, and of course, direct outreach to people at risk of service interruption.
Thank you. Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, and thanks for having this meeting, Chair Huffman, and also, is it Commissioner, Assistant Commissioner? Thank you for coming and testifying. I think all of us care about ending fraud, but we don't want the actual people that need these services, children, disabled, and a host of others that are getting caught up in it. And thanks for your efforts. My question is, I've watched the House committee meetings or the other body on fraud with Chair Robbins. And one of the things that has come up several times and through testimony, I think it's over, maybe it's more than this, but I think it's over 30 employees of DHS who had come forward years earlier about concern about frauds with some of these organizations. And instead of being listened to, they were ignored, threatened, and in some cases terminated from their job for reporting the fraud. So to me, and I think all of us can agree, the people who did this to the whistleblowers, and these are our frontline employees who are trying to be conscientious and report the fraud, which could have been caught years earlier, according to their testimony. Why have the people who did this to these DHS employees who are trying to be conscientious and report fraud, have they been terminated or disciplined? I mean, it doesn't seem like anything happens to these people. I can name a couple names, but I won't. Who did this to the DHS employees? Commissioner, if you would respond to that.
Thank you, Commissioner. Senator Gruenhagen, there's one thing about consistency in all of our hearings this year. He's always asked that question, so I don't know what else you can add to that. But nice seeing you, Glenn.
Chair Hoffman, Senator Gruenhagen, I appreciate this question, and I'll say a few things. I think, first of all, our staff, as well as the community, are key in terms of helping us be strong on program integrity. We need them to be strong voices when they have, an instance of an operational concern, a case of fraud or suspected fraud, some sort of wrongdoing or a problem, any problem in the organization. We need a culture and a process that empowers staff to be able to report those problems. So the things that you are describing, if any of that occurred, is unacceptable. And it is counter to Minnesota law, it's counter to DHS policy, and it's counter to my expectations as temporary commissioner. So I want to say that. Again, what I will say in addition is I am not personally familiar with the individual instances of this happening. I arrived at the department 2.5+ years ago, have been in this role just a couple of months. So I'm not familiar with individual instances of people experiencing what you have outlined here, but certainly if there are instances of that, if people are aware, they should be reported, and we should review those carefully and respond appropriately. But again, we need our employees, they are our strongest asset. We need them to be reporting problems, including fraud. They could do that to the compliance officer, to the inspector general within DHS, to the Office of the Legislative Auditor, the Bureau of Criminal Apprehension. So I appreciate the question.
Thank you. Glenn?
Mr. Chairman, just one quick follow-up comment.
Yep.
I just hope some of these people who did this to the employees, and it's not alleged. Listen to the testimonies in the House Fraud Committee. They actually came forward, some of them, and shared what happened to them. Some of them lost their job. Their families were threatened, according to their testimony. And, you know, if you put me in charge, I'll fire a bunch of people who did this, all right? I mean, this is ridiculous. Nobody loses their job for threatening these employees for trying to end this fraud, which could have been done years earlier. All right, thank you. Thank you, Mr. Chairman.
Thank you, Glenn. I'm going to bring us back to why the purpose of this hearing, and I thank you for that. I think I'm going to Senator Aaron May Quaid next, and then to Senator Rasmussen. So, Senator Aaron May Quaid.
Thank you, Mr. Chair, and thank you, Acting Commissioner Connolly. I have some questions around this 5-month timeline, and I'll just ask them all because you can answer in whatever order makes sense. My questions are like, do you know why 5 months was chosen? And if you had said, because this was the first time in the 60-year history of Medicaid, right, that any state had been given this kind of timeline. If you all had responded, we can't confirm that we can do it on this timeline, what would have happened? Or was there any other options other than 5 months? Was this negotiable? I'm just trying to understand how we got pinned down into this literally first of its kind timeline when every other state gets 2 to 3 years.
Thank you, Senator May Quaid. Commissioner?
Thank you, Chair. Thank you, Senator May Quaid. That's a really important question. So I think the way I would outline how we arrived at 5 months was the fastest timeline on which we could execute this, given the nature of CMS's communication to us both in December and January. So initially, when we, in our first draft of our corrective action plan in December, outlined the requirements of Minnesota statute, the initial response was that is inadequate. That was both communicated in meetings with CMS. It was communicated also via letter and X video from the administrator of CMS. So there was very clear displeasure from CMS with what we had proposed, though that ended up being the timeline that was eventually approved even after the revised corrective action plan was submitted in January and then approved later in March. But that was the fastest we thought that we could execute it and follow Minnesota law, even though there was very clear displeasure expressed from leadership of CMS about that timeline and about the restrictions of Minnesota law. So that was how we ended up with such a compressed timeline, and that was the fastest timeline in which we thought we could execute this. To your second question, forthrightly, the answer is I don't know what would have happened, but what I can tell you is that given the communications and the letters, again, from the administrator to the governor and me, and the deputy administrators to me, and also in the approval from one of the deputy administrators, the director for program integrity, was that this was of utmost importance to them in the corrective action plan. This was the centerpiece. They pressed us to do this as aggressively as we could. And of course, there was a $2 billion threat associated with it. And we felt like we had to do our level best to execute this to preserve that funding for the people that we serve. Given the risk that we had when the letter came with the acceptance of the corrective action plan, what Deputy Administrator Brandt said was, confirm that this is the date that you can meet. And if you're proposing a different date, we need to agree to that. And we felt at that point that we should stick with the timeline given the extraordinary risk to the funding for the program. So that's a description of kind of how we arrived at the 5-month timeline in conversation with CMS. And then to your question about what would have happened, it is unclear, but we continue to grapple with tremendous risk.
Senator May Quaid, follow up.
Thank you, Mr. Chair. And I think there's two things that I think are true in this moment. And one, we live in the real world, right? All of the context under which this is happening is evident, right? It's been said publicly, the retribution campaign, we know that that's happening. And at the same time, I think what would be really helpful is to know and have the department be able to go back and say, this actually isn't a realistic timeline, or we can't do it on this timeline, or send us help to accomplish it on this timeline. Again, I know that could have put things at risk, but I think it always felt at risk with the literal stated retribution campaign. And so I think from sitting on this virtual table, wanting to know that we actually tried to have them meet us part way with a realistic timeline. If we're giving other states 2 years to do this, 5 months is it's just not enough. And so I want us to live in the real world and acknowledge what they have openly said they want to do to Minnesota, but also like we have to make sure that we're communicating back like that we can't do it on this timeline because we couldn't, and that's really scary.
Yeah, that seems like it's Senator McQuay, like that there was that original letter, it looked like there was an opportunity to be able to come back. You know, I couldn't get it done in this time. But regardless, that we know in the future, what should we be doing? Do we need to do something legislatively to get better direction? I don't know. That's the question that's out there. We're going to go to Senator Rasmussen, then Representatives Elizabeth, and then Representative Gilman. That's who I have on my list. Is anybody else? Representative Fisher, you're after Gilman. Is that okay? So Senator Rasmussen.
Thank you, Mr. Chair. I have two questions for the acting commissioner, and so I'll try to keep it brief. First question, Mr. Chair, for the acting commissioner. Could he provide some additional clarity, especially to providers that are watching this hearing today that are in the midst of this appeals process? It'd be helpful to understand the timeline where if we have a provider who has appealed and is going through that, what happens at the end of 60 days? What can they expect to be hearing from DHS, and what can they be telling the Minnesotans they serve?
Commissioner.
Thank you, Chair Hoffman. Thank you, Senator Rasmussen. That is a great question, and I think the first thing to communicate to providers in this forum is that we need everybody to appeal if they intend to continue to provide service. So we have a little under 600 providers that haven't appealed. We encourage them to do so. We continue to reach out directly to them to encourage them to do so. For those that are in the appeal process, we are working with them, I think, in many cases, very iteratively, a lot of back and forth to provide them with information to help them provide the documentation that is required, that we must have. So we can't give on those requirements, but we'll continue to engage with providers to help them provide what is missing or correct what needs revision. So again, 60 days to reply to us within, they must reply within that timeline in order to maintain the ability to bill and to continue to be an enrolled provider. If they are engaged with us within that 60-day timeline, and they are responsive to us within 30 days as we respond to their documentation as it comes to us, we'll continue to work with them to resolve the issues with their revalidation documentation.
That's helpful. Senator Rasmussen, follow up or?
Thank you, Mr. Chair. Yeah, just a clarifying question on that. So if the appeal is not complete at the end of 60 days, so you have a provider who has appealed, is going through the process, maybe making corrections, communicating back and forth with the agency, but the appeal is not complete by the end of 60 days, what happens to that provider?
Commissioner.
If they are responsive to us within the 60 days and responsive to us within a 30-day period of our response to them, we will continue to work with them. So continuously trying to support them through the correction in the revalidation in the provider record.
Thank you.
Thank you, Mr. Chair. And just one more question, then I'll be done if that's okay with you, Mr. Chair.
I'm fine with that, Senator Rasmussen. I think we're going to end up going beyond 2:30 if folks are okay with that, because I do want to hear from the providers and the individuals that were affected by the system that was occurring. So, Senator Rasmussen, to your point.
Thank you, Mr. Chair. And as a question to the commissioner, I'm trying to better understand what went wrong here in this revalidation process and what lessons learned we should have going forward. If I kind of look at the communication that I saw, basically, I wasn't aware there was going to be a major problem and that most providers were going to be denied through the revalidation process. It was notified, I believe, 2 days before the majority of these providers were denied. Throughout the legislative session, this timeline had been agreed to by the Department of Human Services. We were told that the Department of Human Services was working on this timeline, and at least, when I go back and look at my notes, the indications were it was a lot of work, but they were on track and working towards that plan. And to me, when you have a majority of the providers not be successfully revalidated and have to be now going through this appeals process, that's not on track. That's not what I thought the plan was. And so, Mr. Chair, my question for the commissioner is, was this the plan all along, was to kind of do what you can and then deny and roll people over into this appeals process, or when did the agency realize that they were going to struggle to get providers through this revalidation process?
Commissioner.
Thank you, Chair Hoffman, Senator Rasmussen. I appreciate the question. And I think I'll start by saying this was not the plan. We had hoped that the vast majority of providers would be revalidated within the timeline. And the major challenges I think that we faced were, and continue to work through in the appeals, are just the majority of providers that weren't able to provide the information that we just needed. We have to have that information from them in order to revalidate them. So we were unable to get that from the providers that were not revalidated, that were responsive to us. I think that's number one. Number two, some providers, they didn't respond to us until mid or late May. And so that was also another challenge that we had, is that there was kind of a late wave of response, in addition to us being unable to resolve issues through multiple engagements with the providers. And again, we tried our level best to be clear about what was needed and how to rectify issues, and we just weren't able to get there. So it certainly wasn't the plan to have that happen at the end of the 5 months. And of course, I'll go back to my opening statement that we acknowledge this was extraordinary. We did not feel that we could move from, I think, the 5-month timeline, given the communications from CMS, given the tremendous risk to the program financially and to the people we serve. You know, and that's kind of how we landed with the outcome that we have. And the last thing I'll add is that we crafted an appeals process to give providers an opportunity, after getting a notice of disenrollment, to rectify the issues through the appeal and preserve the ability for them to bill for service.
Thank you.
Thank you, Mr. Chair.
Thank you, Senator. Representative Zeliznikar, how are you?
Thank you, Senator Hoffman. I'm well. Thank you for the opportunity, and thank you, Acting Commissioner Conley. My first question is, the previous question on the timeline, the December correspondence, the December correction plan was submitted by DHS. My question is, it's been stated, you stated that CMS stated that was not adequate. What was not specifically adequate in December?
And was that, Representative, that was the corrective action plan you're talking about, right? Is that, yeah, Commissioner Connolly's shaking his head yes. So, Commissioner.
Thank you, Chair Hoffman. Thank you, Representative Zeleznikar. There were a few different things that they requested that we speak to, that we had spoken to in our own department's program integrity playbook, that they wanted us to speak to in that corrective action plan. Those things did appear in the revised draft, things like managed care oversight, things related to program reviews, looking at different benefits for the possibility for policy change to enhance program integrity, recovery efforts in terms of recovering payment after an instance of fraud. So there were a variety of things that appeared in the second draft of the corrective action plan that was eventually approved, submitted at the end of January, approved in March, that appeared in that lengthier version. It's important for me to state, too, though, that we responded to the initial direction to submit a corrective action plan in December. We responded within about 3.5 weeks, so on New Year's Eve, with a corrective action plan that was that included all of the items that CMS asked for, including the off-cycle revalidation of all the services or providers of those services, and the provider enrollment moratoria. So we included those two items that were basically requested or directed to be in the corrective action plan, including others. The original corrective action plan was something like 6 pages, if memory serves. The revised was over 20, I think, if memory serves. So we included much more content in the second version in January, and much of that, of course, was spoken to in our own internal program integrity playbook.
Representative?
Yes, if I can proceed with a few more questions, Senator Hoffman, please.
Absolutely. I mean,
okay.
I think
My second question is it's my understanding from reviewing all the information that, during the pandemic there were procedures that were, policies that were loosened to get program dollars out fast to people, and new providers came into the field. So, you know, we're the programs, it appears to me that the things that we've been asked to do in our state now are things we have actually done before for other programs as far as ensuring those integrity. Is that correct?
Commissioner?
Thank you, Chair. Thank you, Representative Zalesnikar. You're testing my longevity with the department with that question. I arrived in late 2023 as an assistant commissioner, so I am not incredibly well versed on what program integrity interventions historically have been in place for the programs. That said, I know that since I've been in the department, that the majority of my time here has been working on putting in place new program integrity protections. In addition to providing access to service, new services, we're still at work on that, and of course, at the direction of the legislature, implementing new waiver services and new state benefits. So, but I regret that I don't have, having joined the department in late 2023, I don't know that I have, the personal longevity to answer that question fully right now.
Representative?
Yes, and thank you. I appreciate that. I understand you've been there, not in that period, but in the providers that I visited with, there's several providers that have been in business for 10 to 40 years that have had site visits and have done all the provisions that are in the plan of correction and in this revalidation. And there are several that had not had those things. So I believe that that is accurate. My third question is, I'm curious if the Department of Human Services, in your whole strategy of how you selected who was going to be processed first, second, third, the triaged order to get this done, if you were using the data from the Optum report when the state spent $2 million to get an audit done, is that how you chose who you were doing?
Commissioner, please.
Thank you, Chair Hoffman, Representative Zalesnikar. So I just want to speak, I had a thought in response to your prior question, and then I'll get to the order and the question about the Optum report. So what I can affirm is that we have always revalidated providers, and if providers are limited or moderate risk, it's every 5 years. If they are classified as high risk, it's every 3. So we are always revalidating providers, but it's based on their kind of classification with respect to their risk level. So that's always been done. So that is accurate. I wanted to be responsive to that question. With respect to the order, largely we were responding to providers as we received the revalidation, the revalidation documentation from them. And part of that was necessitated by the fact that many of the providers didn't respond to us until later in the 5-month window. So we were trying to be as prompt as possible with the documentation that we were receiving, and have been very prompt, usually within 24 hours, referring providers that had complete revalidation documentation for a site visit from the Inspector General and his team. With respect to the Optum report, that didn't necessarily speak to the risk level of individual providers as we were revalidating them. There were other kind of broader issues spoken to in that report with respect to program integrity issues, but there wasn't necessarily extensive information about individual providers and how we would prioritize them in a revalidation effort.
Representative Zalesnikar.
Okay, thank you. My next question is, in the sense of
You said
the
a couple.
providers.
She said a couple. I guess
Yeah,
the
a
House, you
couple.
guys don't know how to count it too, do you,
No, I
Natalie?
don't. I've spent so many hours on this topic with providers calling me from across the state that I feel compelled to ask a few things.
No, you're
My-
good. Natalie, I'm kidding. I
You
was
can
just,
tease me.
you're good.
I just wanted to ask you.
Great questions, by the way. I
You-
love your knowledge in this space.
Well,
So go.
Does the Department of Human Service have an understanding right now of how many providers are in the northeast quadrant of our state, the northwest quadrant of our state, southeast, southwest, central, the suburbs and metro, that provide services in these 13 categories? I ask this because I have great concern in all of them, but I have an extra concern for non-emergency transportation. I spent 2 years on the ambulance task force and the aging task force. And right now, ambulances are being used for non-emergency transportation because we have no ability to bill. And even if they can bill medical assistance, it's not just the issue of billing medical assistance. If you're not getting payment because they're holding the remittances for 30, 60, 90 days, they can't make payroll. So to my understanding, and we'll hear testimony today to see if I'm right, but to my understanding, layoffs are happening right now and businesses are shutting down and we don't have services. So I'd like to know if we have a provider database that shows who are the providers in the sections of the state so we know what the risk is to vulnerable adults.
Commissioner.
Chair Hoffman, Representative Zalesnikar, straightforwardly, yes, we do have that data. We do know where the providers are and kind of where they are providing service and what types of services they are providing. So we do have those data. And we share your concern about access to care, and I know you and I have conferred about some of the issues that providers are experiencing that you're aware of, particularly up north in the Duluth area and elsewhere. And we share, again, your concern to make sure that folks have access to care. And if there are specific issues, again, that we need to review and look into, I think as we've discussed, we're glad to do that. I know that there is some concern about continuity of payment for services delivered, and we'll, again, try to assess what the issues might be, understanding that if a provider has appealed, again, our policy is that they can submit billing and receive payment if that payment, again, meets requirements. I don't know if there are other issues with system edits with respect to the claims they're submitting that we could work on with that provider or those providers. But again, if there are enduring issues here, we want to work on them and understand them.
Representative, as a follow-up?
Well, my only follow-up is just the piece that I've communicated to you, Commissioner, is that I have great concern that if we don't get this solved soon, these providers in high-risk status that have been vetted through the state from providing services for 10 to 40 years, with site visits, with program integrity, and our relationships with the Department of Human Services have found themselves in the same pool of the bad apples. And so, however, the insurance companies are not going to look at it that way. They are now high-risk categories. And so their credit line loans, the interest rates are 20 to 30%, which is not sustainable. And their insurance providers are saying their rates are going up quite substantially. And so that is going to compress our healthcare model. And my concern is that if we don't get this fixed in a reasonable way to sort through, that we're going to see hospitals being stacked up with patients that could be served in a more efficient way, and our ambulances are going to be in a real predicament. So I appreciate today, and those are my questions right now. Thank you.
Thank you, Representative Zalesnikar. Somebody who's had the knowledge base that she has and years of work in that. I appreciate you being here. Representative Gilman.
Thank you, Chair. Question, I'll start with my question first, and then I'm going to go into a comment as well. So have certain provider types or service categories experienced higher denial or revalidation failure rates? And if so, what specific factors does DHS believe are the driving factors or differences?
Commissioner Conley.
Chair Knorr, Representative Gilman, thank you for the question. Yes, there is some variation among the service lines that are a part of the revalidation, the off-cycle revalidation. In terms of the causes, I think we're still trying to understand those because the effort is still very live. So I think that's an excellent question. Glad to stay in conversation with you about how we understand that, but there is some variation across the service lines in terms of the outcomes of the revalidation.
Representative Gilman.
Thank you so much, Chair. Again, I did get information from Washington that when Minnesota DHS was questioned in this, and on the record, Minnesota DHS did state that the denials or the issues with denials, again, had to do around, the majority of them were around the HCBS services, like the providers, those were the ones that were impacted the most. With revalidation, is that correct?
Commissioner.
Chair Knorr, Representative Gilman, that's a good question. I don't have that information in front of me, but glad to take that back and get an answer for you.
Representative Gilman.
Okay, thank you so much. Again, as we're sitting here, I'm just doing rough math. And when I looked at your slide, it said that more than 100 staff from across the state enterprise have joined your efforts to verify, visit, and validate providers. So you did indeed form a revalidate incident command. Is there 100 folks helping you with that, or more than 100 helping you with that effort?
Chair Knorr, Representative Gilman. So at this moment, the staffing level has been fluid throughout the 5 months. We can get you data based on a certain point in time or currently, but I'd have to go and get those specific numbers for you. But it was roughly 100 at the beginning. It is fewer staff now, and we, because of the flow from the documentation piece of the review to the site visit piece of the revalidation, we had to reduce the staffing level at certain points because we weren't able to see the flow from the paper or the documentation review to the site visit. And a lot of the staff that we brought in were dedicated to the site visit piece of the work.
Representative Gilman.
Thank you, Chair. And so when I look at that and just do rough math, 100 staff, 5,500 providers for 5 months. So they each would get 11 providers to take care of and figure out what's going on with them per month. And I mean, just as a business owner, I would have no troubles getting that done in a week. To 2 weeks. I know that it's staff, again, this is no disrespect, but I want to know, as you're acting commissioner right now, the temporary commissioner, and you're coming and not having the information that we need, this again says to me there's a systematic issue from the top down, from the governor's letter that I got back from them saying, we're bringing misinformation, but the public can only deduce what they can deduce from the information that we're getting. So if I had staff of 100 and I needed to divide it up into 5,500 providers, there would be an expectation by the end of the week, there would be a sheet, a goal list, because you have $2 billion. Again, we can look at the feds all day long, but the fact of the matter is this is happening in our administration's own backyard, and people are impacted. And when we talk about greater Minnesota, folks needing to get to dialysis too, and we've got providers that have been just held out there saying, just figure it out. And we're gonna have to come back. We come back every year, and Human Services gets the biggest cuts. So it's just personal responsibility. It's really frustrating, but when I do the math, unless my math is really bad, it's 11 providers that each person would have to touch and take care of. And that would be my goal, based on what the consequences and the fallout could be. So if you want to respond to that, that'd be great.
Before I go to the commission, I think correcting the math is about 50.
50.
Providers.
Thank you.
So if you're
50.
counting 55, probably, but I know there's a lot
Over
of
5
process
months.
that goes into
Okay.
place for revalidation. So Commissioner.
Chair Knorr, Representative Gilman. So the issue that we struggled with, we were staffed to do the work. The issue was really because we weren't able to pass on the document review piece to the site visit. There wasn't that throughput, and many providers, they didn't respond within the first months of the effort, and so they didn't make it to that site visit portion that the 100 staff were responsible for or brought in to help with. So the issue, again, that we struggled with was really getting through the documentation and correcting the issues with that before assigning the site visit to the staff that were brought in to help. So that was really the issue.
Okay. Thank you.
Thank you, Representative Gilman. Representative Fisher, then Senator Liskey and Senator Holmstrom.
Thank you, Chair Hoffman, Assistant Commissioner, Acting Commissioner. Thank you, Conley. Thank you for being here today. One of the things that, as I'm listening to this past part of the discussion, is a lot of the providers are out there, I know, are very small operations, what I would call mom pop operations. And so they've got their hands full trying to run the daily operation and getting paperwork that they have to do to keep the business running. On top of that, you've got the recertification going on. And it feels to me from what I'm hearing on your discussion here that it seems a lot of people kind of didn't like their taxes. You wait until the very end before you submit for your taxes. Am I accurate in that there seemed to be a large number of them that waited until the end before starting to get some of the information in?
Commissioner.
And Chair Hoffman, Representative Fisher, that is correct.
So what we kind of had is like what I would call when a snake swallows a pig. Everything came in at one time, and as a result, it overwhelmed the system at that point. Would that be an accurate statement?
Commissioner.
Chair Hoffman, Representative Fisher, I think that is certainly a portion of what happened.
Okay, thank you. And then I've got a couple other questions. One of the things that I want to kind of hit on is I appreciate that we're focusing on fraud and we're focusing on making sure we're addressing providers, but I think there's one critical part here that I feel that as I've listened to the discussion that's been kind of missing is, at least from the federal side that is now driving some of the discussions on our side as well, we're focused on the providers and fraud. I don't hear anything about the services as much. When I take a look at the testimony, I see a lot of people concerned about the services that they're losing, their loved ones are losing, et cetera. So while we see the numbers of providers here, what are the numbers of the people of our state that are at risk? I don't see those anywhere here.
Thank you, Representative Fisher. Commissioner?
Chair Hoffman, Representative Fisher, certainly we know that that thousands of people, hundreds of thousands of people likely rely on these 13 services. And we could certainly quantify that for you, and I think that's a really important point. And part of this effort is, of course, to preserve the resources for the people that are served by these benefits, but also for the entire Medicaid program.
Thank you, Acting Commissioner Conley. And it would be great to be able to know what the numbers are being served here, because right now there's a false narrative out there that all these people that did not make it through were providing false services or creating fraud. Having worked in small nonprofits, having watched and talked to small nonprofits in my district, small for-profits that do this kind of work, they're already overwhelmed trying to do the regular business. They are some of those ones that are in denials right now that are providing legitimate services, but we're missing that part of the conversation. So I think it would be very helpful that for us to know is that in terms of the appeals, how many people are we talking in each section? Because some people are saying, well, all these cases are closed, that was all fraud. That's not the case. I know businesses that closed that had to transfer their people elsewhere, that were legitimate services. And I think that's a part of the story that we're missing in the process here, is that vulnerable people aren't getting their services. We need to kind of bring it back and make it person-centered again. I don't feel we're as person-centered, and I'm not meaning it as a fault of the department, it just is the narrative that's been created out there, and I think we needed to bring it back to that. The other thing that I had a question on is I was in the document that you provided us, I was noticing that, some of the problems that TAD was failed site visits out there. Now, having been in programs before that have been licensed by the department, it doesn't take much sometimes to fail a program, to fail a site visit. As you're taking a look at records, et cetera, there's certain things that you have to put in when recertifying. I know that when you're recertified, it doesn't always happen quickly because it's like, oh, we'd like you to make these corrections here or there before the license gets renewed or the credentialing gets renewed, et cetera. And so when I see 916 providers that's failed site visit, I'm kind of curious, what were those kind of violations? What kind of caused it? How many people were being serviced in that? And how many of those were eventually fixed the site, the failures, and were able to come back in to be certified again? So there's a lot of questions. I'm seeing information here, but it leads to these other questions is what is really meant by the numbers out there. So example on the failed site visits, what are some examples that were failures out there that could have been things that were easily correctable but slow down the process?
Yeah. Representative Fisher, you bring up the most important part, which is that continuity of care, the assurance that the services are being met. But Commissioner, if you could look at the second part of his question, appreciate that.
Thank you, Chair Hoffman. Thank you, Representative Fisher. So I want to say first, before I answer your question straightforwardly, that this was a fraud prevention exercise. It is a compliance exercise. So I think it is important for us to make clear, as you're stating, because a provider received a disenrollment notice does not necessarily mean that they were committing fraud. So I think we should state that straightforwardly and appreciate you raising that point. So it is a matter of making sure that certain requirements are met and certain documentation is in place. And then to the site visit portion of your question, when providers submit a complete revalidation, packet, so to speak, to us, we then go out to the site and then verify that information. So making sure that what we see there, what we hear there, matches what's in the documentation. So that's really a key part of the site visit, in addition to being able to have access. And a site visit is just one key tool in program integrity work, that if you go and you lay eyes on a provider site, you talk to people in leadership, the staff there, sometimes the people being served, if you're doing an audit, maybe at different parts in the process, whether it's pre or post payment, that you can verify what's in the documentation. So that's really what the site visit is meant for.
Thank you. Thank you. Senator Liskey, this is what you and I were talking about the other day, insurances, you know, and so to that point, Senator Liskey, welcome to our committee.
Thank you, Mr. Chair. Mr. Chair, Acting Commissioner, I see some numbers and some things on these slides that I guess I'm concerned about after hearing from my actual constituents who have licenses that were either suspended or disenrolled, that I don't think they fall under the high-risk services. FRS wasn't listed as one of the high-risk services, and yet I have FRS homes that are being disenrolled. CRS I don't believe was listed as a high risk, and I have some CRS homes or facilities that have been disenrolled. Are they included in these numbers that we're talking about? At which point, then I think your slide kind of has a weird narrative of high-risk services where it's not all high-risk services. So if you can answer that question first, and then I'll kind of keep going.
To Senator Liskey's point, Commissioner.
Chair Hoffman, Senator Liskey.
Yeah.
Okay. So that is a really important question, and happy to provide clarification about what may have happened there. So my understanding, if I'm using my context clues well, is that for many providers who had one of the 13 services on a record grouped with other services that were not part of those 13, that entire record was included in the disenrollment notice affected by the revalidation. So that it depends on how the provider had grouped the different services they provide on their record. So one way that we've been able to rectify this, for example, is if a provider, and this happened with more than 200 providers in our most revised numbers with respect to appeals, they said, we're no longer providing those services anymore. So we could then straightforwardly remove those services from the record and then proceed with the revalidation without those services on there, or they wouldn't have to go through a revalidation if there aren't high-risk services on that record anymore.
Senator Liskey.
Thank you, Mr. Chair. Another concern that was on that same line, as you stated, there was multiple services on their record, right? So they had a portion were high risk, a portion weren't, CRS, FRS, again, not in the high risk realm, and some of them then were kicked off or, terminated on this window. The concern I have is that a lot of that paperwork should have been something that DHS had and was aware of, right? And so you could have notified them of that specific segment of their record as opposed to their whole record and terminating that. So that's an error, I think, in our pathway of how we terminated people. But then on top of that, some of the site visits that were supposedly done, they failed their site visit. Well, they went and visited them at their home address instead of at the facility address. Well, no one was home because they were at the facility doing the work, and they failed their site visit. Well, how do you fail a site visit if they never actually went to the right site? And so that's concerning. And so something like that, again, in that 916 providers who may have failed the site visit, do we know a number? Do we have a percentage that may have failed it just simply because you visited the wrong site?
Senator Liskey, as you were saying that, Representative Fisher was thinking, yeah, that's the same issue that he was addressing with too. So, Commissioner, to those points.
Chair Hoffman, Senator Liskey, appreciate that feedback and understanding that those situations may have occurred. And I think if there are individual issues like that, we are glad to follow up on them individually, understand what happened, review, and try to rectify. And of course, if we need to go back out for a site visit, if the provider is seeking a revalidation, we will certainly do that.
Senator Liskey.
Thank you, Mr. Chair. And I guess the final thought, and I'll let my colleagues get to some of their points, and I think they're going to ask similar questions that I would anyways. My last concern is that I had, I think, 14 providers in my district reach out to me. 14 providers that had filled out the paperwork to their best of their knowledge, adequately and accurately, all of them sitting on a pending site visit. Many of them had actually filled out and submitted their paperwork early March. So not the window of the group, like you said, there was a bunch that came in right in the end of May. I can understand why that might be a little bit too much. But these individuals had their paperwork filled out well in advance of that pressure, never received a site visit, and then were dropped off as terminated. And so what do we do now? I mean, that doesn't seem like a fair way to terminate. And if that was really just the game to protect the $2 billion was to simply terminate all of them and then come back for an appeals process, I don't think that's a good way to handle this process. And because that, again, continuity of care, they now have to notify all of their clients, all their patients, that they have terminated their agreements because of something DHS has done, and not because they've failed to do the paperwork, failed to do the things that you've asked them to do. And so that's on DHS, that's on us. And it sounds to me like this agreement was made back in December with the federal level, and yet I don't remember hearing anything in any of the committees that I sit on asking for help, asking for us to give you an assistance of some sort to get this along. In fact, every time something was asked about, we've got it, it's on time, we're okay. And that's concerning. We got to the point where it hit May, we were still in legislative body in parts of May, and we were still being told that things were on time. And I don't think that's a good thing. I think that's leading to a process issue, and that's something that Senator Hoffman and I have been talking about for the last 2 months. What happened? Where did the process fail, and why are we disenrolling people that likely had their paperwork done on time, and now we have a continuity of care issue? Because I know for a significant number of my constituents, they've now been displaced. They are now going into institutions instead of staying at the homes or the facilities that they were already at, and that ruins their continuity of care. And some of them may suffer life-altering consequences because of that.
And, you know, because of that, we established in 2026, we established a statewide continuity of care. I mean, it was this legislature that, you know, did that governance. So those are, yeah, I don't know if there's a response to that, Commissioner, but that gets to the essence of this whole conversation, is what Senator Liskey was talking about, right? It's like, and we know that there was some, you know, we had heard that, you know, the feds said, well, if they don't respond, just shut them down, right? Well, I'm not even going to buy into that, right? What I'm going to buy into, the fact is, all the debate that was going out there, it was still that point that I just drive home. Senator Liskey just drove home there too, is that assurance of the continuity care piece, right? And so I don't know if you have a follow-up with that, or if we want to go to Senator Holstrom, or did you have a follow-up you wanted to do, Senator Liskey, Commissioner?
Chair Hoffman, Senator Liskey, I appreciate that feedback. And I think anytime we've heard an instance, whether, you know, from you all or from the media, of something happening or going awry with the operations of the effort, we have tried to follow up on that. To my knowledge, have followed up on that, tried to get to the bottom of it and rectify what happened, and of course, engage with the providers to help them move forward in the process. So what generally I have been reported by staff, again, understanding that we are not perfect, I said that at the outset, is that once providers have a complete record in terms of the revalidation and all of the different things, insurance, credentials, training, verifications, information about ownership and leadership, within 24 hours, we're able to refer them to a site visit. So I can't speak to the individual instances, but as they've appeared to us, either in communications from you all or in the media, we are following up on those and reviewing and trying to rectify if anything needs rectification. And then with respect to the resources, certainly we did, you know, and are thankful to the legislature for resources to enhance our program integrity staff. Over 450 folks will be joining us in the upcoming 2 years, and a share of them will be in provider enrollment and compliance. So we do have capacity needs, and the legislature responded to that, and we're grateful for that investment in the work.
Thank you, Commissioner. Senator Holmstrom.
Thank you, Chair Hoffman. We were invited to this committee, and the goal was to try to keep this as nonpartisan as possible. And we started out with some partisan framing, and I kind of want to recenter that framing under the understanding that, you know, it was said that the federal government weaponized $2 billion, that this was some sort of retribution campaign. And again, to recenter this, the American taxpayer was defrauded, not the Minnesota taxpayer, not just them. All American taxpayers were defrauded. These were federal dollars. And CMS came to Minnesota and they said, hey, let's have a conversation. We're going to put some standards down. We need this to be rectified. And CMS came to the table and they said 5 months we can do this. That was the number that DHS brought forward. So I don't understand where this framing comes from that the federal government is the bad guy here. These failures are our own. Minnesota failed, and this is what happens when you fail. You know, we get expectations set upon us that we need to meet. And to that point, I'm looking at the numbers, and I don't see a number provided for how many providers failed revalidation or on appeal due to fraud. Do you have that number?
Commissioner, do you have that number?
Chair Hoffman, Senator, so I think it's an important question, and at this point, fraud is an intentional act and a crime that has to be proven, so we don't have a number of providers that have been proven to have committed fraud. What I can say is that 59 providers is the most recent number that I have in terms of different providers that were referred to the Inspector General for program integrity concerns as a result of the revalidation effort. What I can say, though, is that since the beginning of 2025, we have referred over 700 cases for investigation by the U.S. Attorney and the Attorney General here in Minnesota for fraud.
Thank you for that response. Senator Holstrom, and then go ahead. Senator Holstrom, you want to follow up for that?
One more follow-up. So the other goal here is we want to try to get this back on track, and I see that there are more in appeal right now than had actually originally been revalidated. So to that point, how much staff today do we have dedicated to that appeal? And you said that you crafted a new appeal process. My concern is that we might lose some of the fraud because we have a process that's understaffed and relatively new. So do you know what the staffing numbers look like today? And is there a plan to increase those staffing numbers so that these providers can be relieved of some of this pressure and we can get through this while still maintaining integrity?
Yeah, I think the point there, you know, Senator Holster, that like our whole bill last year was all about that program integrity side of it. So it'd be maybe in the off, take a look to see if there's anything, you know, that's a gap in your background in 245D, you know, which is basically the whole gist of human services. It would be nice to get your input on that one as well. But the response to that, and then I think we'll go, Glenn, sorry, we're running. I want to get to hear from the providers, so I'm going to go to Representative Noor. I'm going to forego my questions that I had because I really want to hear from the providers in the amount of time that we have about what this did for people that should be getting services. That was our whole conversation. So if we could do that, I would appreciate that. And thank you, everybody, for hanging in there with me. So, Commissioner?
Chair Hoffman, thank you. Senator Holmstrom, thank you. So with respect to the number of staff that are working on the revalidation effort, that has been a fluid number. So our Medicaid provider payments Medicaid Payment and Provider Services Division has flex staff to redirect them to the revalidation effort. So at this point, as needed, as the paperwork is coming in, as the documentation is coming in for the revalidation effort, we have flexed. And of course, as the workload has ebbed and flowed throughout the process, and as the appeals work has ebbed and flowed, and of course, we're at a flow at this point, given the number of appeals we're processing. We have more from that division dedicated to the work, but that's been a fluid number, but I can certainly try to get you an estimate as of today.
Thank you. Chair Noor, and then take us into, Commissioner, thank you for hanging out with us for the whole hour here. And Chair Noor's got a couple follow-up questions, and then we'll go to hearing from the public. So thank you. Chair Noor.
Thank you, Mr. Chair. Commissioner, thank you so much. I think from the corrective action, there was about close to 20 elements that we included in there. One of them was the off-cycle revalidation, which we're talking about right now. And one of the other elements was the moratoria. The corrective action plan goes beyond just the off-cycle. It goes up to 2028 in terms of meeting some of those guidelines that we have indicated that there's specific timeline included in there. So I'm assuming that there'll be moratoria for the 13 program, or maybe less because I've had it's going to be 12 program. I don't know which of the programs service area was removed. I don't know if you can give us a little bit of a briefing in terms of where we are in general, and also if the moratorium will be continued, because that the deadline for that was June 27, 2026.
Commissioner.
Chair Hoffman, Chair Noor, thank you for the question. You're right, there are a variety of different pieces to the corrective action plan. In addition to the revalidation effort, there is the provider enrollment moratoria. Those are renewed in 6-month intervals by CMS, and of course, part of that is looking at continuity of care and looking at network adequacy. So that's a part of the analysis that we conduct with CMS every time we renew that. So we did renew it just recently for the 13 services in focus today. And as we move forward and look at different program integrity issues, the implementation of the corrective action plan, we know all of these services may be positioned differently in terms of their risks and issues. I think to the statements we made earlier about different trends and patterns among the providers and billing, those things I think will look different among the 13 as we move forward. So when we feel like we have the right controls in place, we feel like billing is being scrutinized appropriately and things of that nature, it is possible we can remove that high-risk designation and the enrollment moratoria, but we'll continuously evaluate that. And of course, the moratoria happens in 6-month intervals, or is applied in 6-month intervals.
Commissioner, just following up, I think I wanted to check in with you. One of the challenging piece that we have is the provider enrollment processing, because that has created a significant delay for many providers who are not even under the 13 program because of the requirements. That significant delay was already posted by DHS saying that there'll be delay, but to some extent, it's actually creating issues with continuity of care. Because some of the changes individuals are making, like the controlling individual, management officials, that results into the suspension of payment. The billing is suspended for some of those providers. Some of them since last year, since starting the beginning of the year, January, their billing has been suspended, and they've provided the documentation necessary to proceed with the program enrollment process. But unfortunately, I think that there's been a significant delay. Is there any way to really put that as a priority to make sure that the provider enrollment process is resolved so that no one loses care? Because I'm hearing from providers who are saying they will shut down because they can no longer provide services whereby their billing is inhibited and they can no longer do that. Because I don't know if they will be able to appeal the process. Just the delay because of the provider enrollment is creating the issue.
Chair Hoffman, Chair Noor, thank you for the question. I want to make sure that I understand the question. So this is an issue with respect to new provider or new service enrollment relative to revalidation, because we prioritize the revalidation effort and providers being unable to bill because they're unable to enroll in certain service lines. Is that the question? I want to make sure I'm responsive.
So it's a twofold. As part of the provider revalidation, there's so many changes needed to be implemented to make sure that they're in compliance. So we're looking for that compliance requirement. But one of the other big challenge is regular enrollment changes now triggers payment suspension to those providers, and the continuity of care now is significantly impacted. In fact, I was talking to a provider who was told that because they submitted their documents on January 23, and they were supposed to send it January 20, they'll still wait in the process. And likewise, I think because of the rules that we have, if there's any additional requirement from the department, you go back to the lane for 30 days. And then if there's something new, that cycle needs to end. Commissioner, I think there's a problem with the provider enrollment that I think needs to be prioritized in order to make sure that we do the same process. Continuity of care impacts everyone, regardless of the 13 high-risk program. But quite frankly, that is one of the challenging pieces that we see at this point.
Commissioner.
Chair Hoffman, Chair Noor, thank you. Yes, this is something that's been brought to our attention in different meetings with providers. And certainly we hope that as we work through the appeals that we are processing now, that we can then revert back to more regular business, so to speak, that we can start working on some of those different provider enrollment submissions and that workload. So it is something we're aware of. We do want to pivot back to that business. We understand that providers seek to make changes to their service mix, and we want to engage with them and make sure that we have access to care. So we'll continue to work through the appeals and hopefully be able to rebalance our workforce back to that workload as well. The other thing I just wanted to add to is we're aware of some other issues like service agreements, and are trying to speak to those issues as well through different approaches that providers can take in terms of issuing a service agreement through the termination date or the ending date of their enrollment, and then working with lead agencies to resubmit a service authorization if needed. And that's specifically for CFSS and PCA services. For the other high-risk services, they can submit that, or they can receive a new service agreement now. So we have rectified or clarified that issue. But we'll continue to work through these issues with providers and, of course, rebalance staff according to the need and the workload as it comes in. But aware of the issues and certainly want to continue to work on them and in partnership with you.
Mr. Chair, thank you, Commissioner. I think one of the other follow-up is because those changes need to be done through the MN login. We are seeing a significant problem, which I'm also concerned. This is also starting to have an impact to recipients, which requires also, if they cannot validate themselves, they have to go to the registrar's office to get a documentation for them to be authenticated in order to receive services. That's a different topic, but it's also having a significant impact for those who are trying to access the portal to upload those documents, and I'm hoping we can have a quick turnaround on the login MN. I hope we did not undertake the changes during this whole crisis timeline that we have, that we ended up changing the technology. One other piece that I just wanted to note, through this revalidation process, we've seen providers who've been providing services for actually more than 10 years, who have been given the documentation to provide service under a specific program. All of a sudden, they're being told that you don't have the right credentials. In fact, some of them, I had checked the Minnesota healthcare program. When I checked, everything looked fine. And then all of a sudden, even if when they appeal, those services now completely terminated and then removed from the Minnesota healthcare program. And they've got nowhere else to go because they don't know what to do next. And it also impacts that continuity of care. I'm hoping we can find resolution on multitude of issues, and you'll hear from the testifiers today who will be talking about that. Thank you, Mr. Chair and Commissioner.
Thank you, Mr. Chair. I want to thank Commissioner Connolly for coming in and your willingness to answer really difficult questions. But this system is about the people that we serve and the providers and the fact that we should be fully transparent and aware of what's going on. So I appreciate you coming in front of this committee to have this conversation. This just kind of spells out what we need to be thinking about in the upcoming session as well. But thank you for your time. And with that, Commissioner, I again appreciate you being here. Members, we're going to transition. There's 11 people that are testifying, and we were thinking we could do 3 minutes each. I'm asking you to go to 2 minutes. But I noted that a lot of people that had testified, for the record, you had sent letters in as well. All these letters will be part of the committee record and be shared with the department. Again, thank you, Commissioner. And so with that, I'm going to ask if you'll also send us letters, or if you did not, send a letter in as well. But we're going to go to Zoom first, members. Linda Fairchild, owner of Fairchild's Foster Care, and then up will be Lance Egley will be second. Tricia Brisbane, if you're in the hearing room, why don't you work your way down to the table? And Fatima Molis, you can work your way to the table as well. So with that, Linda Fairchild, you're on Zoom, I believe.
Hello, Senator. Honorable Senator Hoffman and Human Services Committees. Can you hear me?
Yes, we can absolutely hear you. Thank you.
Perfect. My name is Linda Fairchild, and I'm a family residential service provider in Wright County. I've provided family residential services since 1988, so 37 years. On 5/31/26, I received a termination letter, which surprised me as I had done my revalidation in 2024, but has always been pending. I was first asked to complete my revalidation January 16th and 24th. The letter told me I had 30 days to comply and finish the request to maintain my license. I submitted my information January 22nd of 24 via the online portal. On March 27th of that year, I received a request for more information. I resubmitted that information on April 6th within the 30 days time, and on April 26, 2024, the request detail report for revalidation portal stated complete. Thought I was done. My revalidation, however, kept saying pending, so I sent notes to the portal stating, when I print the provider report, it doesn't show what you've changed, doesn't show anything that was modified. How do I know if the documents are correct? No response. My revalidation continued to be pending via the port site until April 26th, or from April 26th until May 31st, 2020, or I'm sorry, I'm trying to do it fast. So from April 2024 till May 31st of 2026, when I was told via letter, my record was terminated because I failed to revalidate or to respond to notices in the provider portal, and my compliance was not complete. I had gotten no more messages. I had completed all my requested materials. DHS had required billers in April to take a minutes training. When I tried to upload my minutes training, that was mandatory. I couldn't because my status was still pending. Due to being pending, I couldn't upload, so I had to call the provider helpline to get this done so I wouldn't be terminated. I waited on hold for 2 hours. They then told me that they couldn't figure out what was wrong, so I was given a ticket, told that I needed to talk to a provider enroller specialist. The provider enroller specialist said that since I was pending, I couldn't upload, so I couldn't change what I needed to change, but she was able to help me. She then reviewed all my documents on May 20th so that I wouldn't be terminated on May 31st. But I got terminated. Now, not only has my family residential services home had a budget decrease of 43% because of the flat rate, I got terminated and I had done everything that I was asked. Yes, while this is pending, I can bill, but to the outside world, to everybody that reads the documents related to my home, I am now a fraud risk. I am now in fear that the state could close my doors and remove those I love. That's not fair. I did the right thing. This may be the straw that breaks the camel's back for many family residential service providers, because with the significant reduction in reimbursement, it's tough enough to know how to deal with things. And now, if I can't keep my license open, that's even more stress. This needs to get fixed. I've done everything you've requested and I'm still penalized. I'm still terminated at this point. I hope this gets fixed so I can continue to care for those in my home and not feel like I'm always in jeopardy. Thank you for the time.
Thank you, Linda, for your testimony, and I believe Senator Liskey has shared your emails that you have sent to him in the past with a lot of people. So, Lance Egley, you're on Zoom.
Honorable Chair Hoffman and committee members, my name is Lance Egley. For 4 years, I've been leading the provider efforts on systems improvement and paperwork reduction. This gives me ongoing contact with SUD providers and repeated updates. It includes more than a year working with DHS, a large group of providers, and 2 national consulting organizations. After May 31st, DHS revealed that a huge portion of the programs, I guess you know this now in this committee, were disenrolled. This is going to cause significant problems for clients and providers you're now aware of. And sadly, this all would not have needed to happen as severely if there were better communications between the Department of Human Services and providers. Among programs that did not apply, several thought they need not apply because they actually didn't use the risk service peer recovery support specialists, and then didn't get letters that they were supposed to receive, possibly because, yes, Representative Norway did start a new communication system in the middle of this crisis, and they either didn't see them or didn't get them at all. And so they only knew that they were supposed to apply when they were disenrolled. Oddly, this is a circumstance that I think Commissioner Conley just said that wasn't supposed to happen if you had services on your license, but you didn't use them, or that you could have stated that you don't have them. Many other programs were disenrolled later because of missing documents, and the programs were firmly convinced those documents were never missing. Lost documents have been a long-term problem at DHS, especially at licensing, and the report recommendations for minimizing regulatory paperwork and improving systems for substance use disorder programs already has recognized this as a problem that needs to be fixed and recommended an electronic fix. It's just not in place. These patterns have been around for years. It's taken a long period for the department to get through the process. Another pattern that was identified was billing interactions between payer operation changes and electronic health record systems that are widely used by providers. So for instance, at the end of this revalidation, when several firms reapplied and they were approved and the funding was turned on, they couldn't bill for over a week because the portal wouldn't accommodate what the EHR operated on. And the EHRs luckily solved this problem just one day before it would have been 2 more weeks before they could bill.
Thank you.
Communication problems, underlying interaction problems between computer systems, these are basic problems that have been going on for a long time, and they set us up for failure every time we want to deal with a crisis. In fact, they set us up to have more crises.
All right. Thank you, Mr. Egley. I appreciate
So
your
I
information.
want to recommend one thing, and that is that we need a recess hearing on the DHS report so that we can get enough attention back on it to do something. Thank you.
Thank you. I believe that's the Optum report, and I am waiting for somebody from a certain Senate district to send me a piece of paper to sign. So, Tricia Brisbine, you're next on Zoom.
Thank you, Chair Hoffman and members of the committee. Charlie was not having it with Mom leaving the house today, so thank you for the opportunity to talk to you via Zoom. I'm a disability advocate and mother of Charlie. Charlie has intellectual and developmental disabilities. The efforts to prevent fraud and ensure accountability among Medicaid providers are important and necessary. However, the implementation of this provider revalidation process has had serious and unintended consequences for Minnesotans with disabilities, many of whom have experienced significant disruptions in essential services. The impact on these individuals and families has been profound. I'm gonna give you just a couple of quick instances. A friend of mine, a mother of 4 children who receive services, 4 children with disability services who rely on personal care assistance, PCA services, for their daily support needs, lost all 4 of those the child's PCAs with little notice. Now, remember, these services include basic things like bathing, eating, toileting. The family was told that the provider was not revalidated because a required DHS site visit had not occurred despite the provider's efforts to schedule one. In another case, a young man living with his parents lost his PCA services and supports when his agency failed to receive that validation. Family was told that the denial resulted from an administrative discrepancy because some documents listed the former business manager who had retired, and other documents were updated to reflect the new business manager who had taken her place. Finally, there was one adult with significant disabilities that has been without essential in-home services for more than a month. The resulting unmet care needs contributed to a medical crisis that ultimately required a week-long stay in the intensive care unit. I think we're all very happy to be able to say she's still with us today because we weren't sure that was going to happen. These are not isolated incidents, and these results have been devastating. Just a few thoughts after hearing everything that I have today. So these providers were given DHS approval to provide, they submitted all the necessary documentation when they established as a service provider. And each time their cycle came up, whether that was 3 or 5 years, most of them could get done what they needed to. But in the last 5 months, that many providers had problems coming up with it. And we keep talking about services again. Remember that these services are basic needs. So we should be asking, are participants able to continue receiving services throughout the appeals process? I've heard some dancing around this issue, and I think that, there may be different times when they are able to, but not always. And the more important issue is, what is in place to protect the continuity of care when any necessary services are denied or terminated? Thank you, Chair and members of the committee, for your time.
Thank you, Tricia, and hi to Charlie for me, William. Thank you. Fatima, welcome.
Thank you. Good afternoon, Chair Hoffman and committee members. My name is Fatima Molas. I'm the co-founder and the chair of Multicultural Autism Action Network, MAN. I'm also a mother of a son with profound autism. I'm here today not just as an advocate, but as a mother carrying the pain and the fear of an entire community. I need you to understand what's happening to families right now. Our phones have not stopped ringing. Parents are calling us crying, panicked, desperate, asking, what do I do now? Who will help me? How do I keep my child safe? I spoke with a mother caring for her adult child with complex medical needs who must be turned every 2 hours to prevent serious harm. Because of the service suspensions, she lost all of her staff overnight. She has not slept. Imagine being afraid to sleep, to close your eyes, because if you fall asleep, your child could be harmed. Imagine lifting, turning, monitoring, and doing everything alone until your body gives out. That's not caregiving, that's survival. And this is not one family. Parents across our community are collapsing from exhaustion. Some are quitting jobs. Some fear their children will end up in the emergency room, hospitalized or institutionalized, not because they failed as parents, but because the support holding the families together was ripped away. Summer is here, and our children's needs do not disappear when school ends. Children with autism and disabilities need routine behavioral support, supervision, and consistent services to remain safe and regulated, like my son Noah, who was up the last 24 hours. These services are not luxurious. They are lifelines. They are the difference between stability and crisis, between safety and danger, between survival and collapse. Please do not reduce this to paperwork or policy. This is human suffering. Tonight, when you all go home to sleep, many parents in our community will remain awake, lifting, turning, monitoring, and de-escalating, praying their child makes it safely throughout the night. Families are drowning. Please act now. Thank you for your time.
Thank you for your testimony. Thank you.
Thank you for listening.
Dr. Larson, Amy Nguyen, and Olga Shavaleva. I hope I said that right. Dr. Larson.
Thank you. Chair Noor and Chair Hoffman, members of the committee. I'm Dr. Eric Larson. I'm the chair of the Autism Treatment Association of Minnesota. I'm a licensed psychologist, and I've been providing intensive early intervention services to kids with autism in Minnesota for 40 years. Our program, the EIDBI program, is a heavily regulated program that is not suffering disenrollment terminations because of credible allegations of fraud. Instead, it's about a rushed effort to complete large amount of paperwork using a very antiquated documentation submission system. I'll skip over all the details. There's so many different glitches that occur for each provider, but the average provider that we're talking about goes through 3 to 4 cycles once a month of submitting forms, getting feedback a month later that the forms are incorrect in one way or another, correcting those, and then getting new feedback a month later. So most of us were not able to get a site visit by the deadline, and were then disenrolled because we hadn't completed the requirements. Our request is that there be a temporary waiver of the restrictions on enrollment of new providers that we hire to provide the services to our families, and waiver of the restriction on authorizations. So each one of our kids are required by DHS to submit a new treatment plan for every 180 days of services, and our providers are not able to submit those treatment plans right now. DHS very genuinely opened up the ability to bill for the services, but if we can't get the services authorized and we can't enroll the new staff to deliver the services, then we can't bill for the services. So we're watching an increasingly lower and lower number of potential billings coming in every 2 weeks. And the conclusion of our fellow providers is that on average, we can last about 3 months of services before we run out of the funding we need to serve those kids. And if we use the projection from Commissioner Connolly's report, it's going to take DHS 7 months to complete all of the revalidations. And our providers will have to conclude services within 3 months, dating from June 1st. So we're asking for a waiver of the current restriction on submitting authorization requests and enrolling new employees.
You know, thank you, Dr. Larson. I've known you for many years, and back when, in 2000, even 2001, it goes way back to when there was a debate over EIDBI, autism services, and ICI. You had these 2 different camps. Your name, your face has been part of autism services, not only just here in the state of Minnesota, but nationwide. And to hear you say the system failed you, failed the people, the many people that I've known your work is done for. I hear you, and I hope the commissioner is hearing you on the waiver side of it as well. So thank you for your testimony, and thank you for your service for many years. Amy Nguyen. Amy's not here.
Hi, can you hear me okay?
Oh, you're on Zoom. I'm sorry, I didn't have you down as Zoom. I should have had you right away. So go ahead, Amy.
Yeah. So Chair and members of the committee, my name is Amy Nguyen. I have served as Program Director for the Pine River Group Home for the past 7 years. We're a nonprofit provider located in rural northern Minnesota that has served people with disabilities for over 45 years, currently supporting 39 individuals. Our organization is one of the many providers affected by the recent revalidation process. Despite completing our revalidation requirements by March 2nd, not a late May submission, DHS disenrolled us and immediately suspended our payments for all of our service types on May 31st, including our programs not on the list of 13 high-risk service types. Although payments were later temporarily reinstated, as of today, our organization still has not received all amounts owed to us, and DHS still has not completed its full review of our appeal, including our required site visit. Our situation remains unresolved, and if DHS does not complete these steps before its next deadline, it's unclear what will happen to providers like us. What does work with us really mean? Does that mean payments will continue? We completed our revalidation and appeal on time immediately as directed in consultation with a DHS representative and an outside expert. We have had no findings of fraud, wrongdoing, or noncompliance. I also want to note that we were never required to revalidate until 2025, and that submission was still pending review when we got our most recent request. 2025 submission disappeared from the portal. We have never been asked to revalidate every 3 to 5 years as stated here today. DHS has publicly stated that they completed their review by the deadline. That is not what happened here, not only in our case, but for many providers. They did not complete required steps. The public messaging has been misleading and lacks transparency. Providers like us are being grouped into statistics that suggest non-compliance and fraud, when in reality, DHS didn't meet their own obligation. This has caused significant damage and trust between DHS and providers. We continued providing care without reimbursement for almost 2 weeks, and as a small nonprofit, we do not have the reserves to operate for long without payment, about 50 days to be exact. If we cannot sustain operations, the impact of this goes far beyond our organization. To the more than 60 employees who depend on these jobs, the local businesses and community that rely on our presence and patronage, and most importantly, the individuals who rely on us for their homes, care, and stability. We did our part, we followed the process, we met every expectations, and yet we are the ones that are at risk. We are left with no reasonable alternative but divert time and resources away from serving vulnerable people in order to defend our ability to continue serving them. This is not accountability, it is not a provider failure, it is a system failure, and it needs to be corrected before more vulnerable people are put at risk. These are not numbers to us, these are people we know, people we deeply care about, people whose lives depend on the care we provide. We are asking for accountability, transparency, and a process that protects vulnerable Minnesotans, preserves critical services, and prevents situations like this from happening again. Thank you for the opportunity to speak today.
Thank you, Amy. I'm going to have Olga Shevalieva, you're next, and then Susan Rosette and Mark Mata. If you want to work your way down to the table, that would be great. Ms. Shevalieva.
Chair Hoffman and committee members, thank you for the opportunity to testify. I'll try to be brief. My name is Olga Shevalieva, and I serve as the Vice President of Metropolitan Community Services. We're a nonprofit, multi-specialty, essential community provider serving approximately 430 people through our in-home service programs. We're also a culturally specific provider specializing in services for Minnesota's Eastern European communities. The issue I came to talk about is to share our experience about a failure of a site visit due to managing employee information that DHS determined has not been disclosed. Our agency believed that all managing employees had been disclosed multiple times in response to DHS and managed care organization requests over the years. Because of that understanding, during our site visit, we fully and transparently identified all managing employees, including their names and positions, when questioned by the surveyor. Following the visit, however, we received a termination notice from DHS stating that our enrollment was being terminated because we had failed to disclose management officials. This came as a surprise to our organization. Both my supervisor and I were under the impression that this information has been submitted through the MPSC portal. After receiving the termination notice, we reviewed our records and found that the information was no longer reflected in the portal. It's possible that the error was originated on our end. However, while participating in various provider meetings, including DHS roundtables, I heard reports from other providers describing similar experiences involving the loss of information in the MPSC portal. This suggests that the issue may warrant a further review to determine whether there are system or process challenges contributing to these outcomes. The consequences of enrollment termination are immediate and significant. Our agency immediately lost access to minutes eligibility verification, service authorizations, and billing submission functions. This created substantial uncertainty for our staff and concern for the individuals who depend on our services. The loss of access to service authorizations creates barriers for new participants who are ready to begin services, as providers cannot admit them without an active service authorization. The inability to submit claims creates additional financial hardship for providers who have already faced significant financial strain due to recent DHS prepayment audit, the liquidation of UCare, and delays associated with transitioning members from UCare to other health plans. Significant delays, I might add. We respectfully ask policymakers to review their validation process, improve communication regarding enrollment requirements, and establish safeguards that prevent immediate service disruptions when administrative discrepancies are identified. Consideration should also be given to corrective action periods or temporary access protections that allow providers to resolve administrative issues before enrollment is terminated and services are disrupted. Such measures would help protect providers, preserve access to care, and ensure ensure continuity of services for the Minnesotans who rely on these programs. Thank you for your time, and I'm happy to answer any questions.
Thank you so much for your testimony. We'll now go to Susan Rosette. Please introduce yourself and proceed with your testimony for 2 minutes. And Mac, Ken, and Paul, please get ready to come to the testify table.
Thank you, Commissioner or Chair Noor. My name is Susan Rosette. We got magical chairs going on here. My name is Susan Rosette. I'm from Cardinal Comfort Care Cooperative, and we are in Two Harbors, Minnesota, right on the beautiful lake of Lake Superior. We provide 245D services, in-home services, and also the essential non-emergency medical transportation. We are the only non-emergency medical transportation in Lake County, and we provide services from Grand Portage all the way down to the Twin Cities. And there is a tremendous need there. I've heard so many wonderful, good stories about what has happened to providers. And I'm here again. I was here earlier this year, but I'm here this time with practical solutions to the ongoing DHS issues. Home and community-based services are critical to the safety and well-being of our communities. We all know that. And the unprecedented challenges of our organization has faced over the past 8 months have significantly reduced our ability to deliver care. So we have experienced an approximate 70% reduction in client care capacity for DHS, workforce stability, and the overall provider operations. And the state is currently holding over $60,000 in services already rendered. So as we have to navigate staffing in order to make sure that we make payroll, it hasn't been pleasant at all for the past few months. A major contributing factor has been ongoing prepayment reviews required for the continuation of our services. And this process has created an unpredictable, unsustainable financial environment. We do not know which remittances will be paid or when the payment will occur, making it extraordinarily difficult to manage payroll, maintain staffing, and ensure continuity of care. It is not reasonable to expect a professional organization to operate under these conditions. The impact is not only operational, but is deeply human. These disruptions directly affect vulnerable Minnesotans who depend on consistent, reliable supports to remain safely in their homes and communities. Many are currently in crisis and remain unserved and underserved throughout the state. We care about all of Minnesotans. I respectfully urge the committee to take immediate action to stabilize providers and preserve access to care. Specifically, I ask the state, one, to establish a provider impact task force charged with working alongside of DHS in a true partnership model, one that values provider expertise and anticipates real-world consequences before policy implementation. Number two, I require formal stakeholder engagement through focus groups or feasibility studies on ongoing service delivery conditions before enacting additional administrative requirements or barriers that impact fair business practices. Number three, provide immediate relief measures that bring predictability to the payment system and reduce administrative burdens that are currently destabilizing the workforce and limiting service access. And four, we all know that there's federal changes happening. And I encourage you to prepare. And I think we need to prepare. And by that, I mean including the option to transition providers and workers into a state-employed model to ensure workforce stability and maintain uninterrupted services for Minnesotans who rely on care. This is a very important piece to the ask because I think it's like playing chess right now. And many of the providers are losing. And it's important that we position ourselves so we're prepared for what comes down on a federal level. Minnesota has long been a leader in supporting home and community-based services, Maintaining that leadership will require urgent attention to the unintended consequences of current processes and renewed commitment to collaboration between state and providers. Thank you for your time and your leadership and your commitment to the people of Minnesota. I would welcome an opportunity to provide additional insight and discuss solutions that support both accountability and sustainability. I would like to add, the only reason we are still providing and in business is because we had to pivot to private pay. Private pay is what is making us float. This is a shift from to serving the most vulnerable in our communities. We want to serve them, but we've been forced to serve those that have instead of those that do not. That concerns me.
Thank you. Thank you for coming down from Two Harbors.
Thank you.
Trip down. I appreciate that.
I appreciate it.
Mark Mata, you're the owner of Hennepin Home Healthcare, Inc., and then followed up Ken Bentz and Paul Verrett. You coming, but I think I see Luella here, so I'll wait till Mark's done, and then you guys can just come on up. So, Mr. Mata, welcome.
Senator Hoffman, so I can give credit where credit is due, so I don't get another termination letter. My wife, Amelia, is the owner of Hennepin Home Healthcare. By virtue of marriage, we are both owner-operators.
Thank you, and as a constituent, I appreciate you telling me that.
Thank you. The last time I was in front of a board was TIF districts in 2005.
Thank you. Welcome.
We are a 3-generation home health care company. We've been around since 1974. That's 52 years. We've gone through 3-year validations because some of our services are high risk. We have 18 services we provide. Of the 18, 4 are in DHS's determined high-risk services, which means a large grouping of them are not. We happen to have 3 provider licenses, we'll call them, provider programs. So we were denied and terminated in all 3 of them. We had site visits. We turned in our documentation through the email portal. Upon the site visits, all 3 terminations were for technical issues that made no sense. They could have been determined in about 5 minutes each. One site, first of all, we only have 1 site, but yet 3 different people came out doing the site visits. Why wouldn't you send 1 person? There's obviously a disconnect in who put this whole program together because there's so many inefficiencies and waste in itself. The first one came out, they talked to my HR person. He's a managing person. They asked him about being on the board. He shows up to the board meetings. He's not a board member. We only have 2, the president, me, CEO, my wife. When they went back, we got a termination letter stating that Brad had stated he was a member of the board. Not the case, bad interpretation from the person who did the site visit. Second one came in and asked about who's the owner. My wife and my HR person are sitting next to each other for the interview. She says she is. They went back, the termination letter, and that one stated, Brad Wing stated he was the owner and owner of Hennepin Home Healthcare, did not match the portal. Termination letter number 2. The third one, we were terminated because they said I was the designated biller on record. I'm not in the portal because nobody had mentioned we need to be in the portal and put my name as a designated biller. They asked a question. Again, we filled online all the information out stating who was your designated biller. They stated me. When they came there, they asked us. Now, in order to be a designated biller, we were grandfathered in. That's a new requirement. We've been around for a long time. I actually had to go sit through 2 4-hour trainings back to back on June 2nd and June 3rd. Let me tell you, they sent me an email, a link to a webinar on June 2nd. The moderator said there's about 200 providers in that seminar, which meant there were going to be 200 the next day on Wednesday. The 3rd, I get to log in, go to click the blue box from the DHS portal, cannot get through. Pay $200 to my IT tech to try to figure out how to get me through here. He says it's broken at the department's, at DHS's side. This is DHS. How can this be broken? We finally get on by cell phones. Other competitors of mine are texting each other back and forth. Are you on? Are you on? We decided amongst a group of people helping each other out. These are competitors. We got on through watching a webinar. Can you watch a webinar on this right here at the DHS doing statistical presentations? You cannot. They at least acknowledged, but they said if you didn't get on this presentation within a timely fashion, you had to start again in July. Thank goodness we were able to get on about 45 to an hour late. They still never acknowledged to anybody by email that that was broken. Just turn around and say, we're going to have this tomorrow when we can fix the webinar, or the next day. So when you talk about putting loopholes and things that we can operate in, this is just kicking the teeth after kicking the teeth. And that so many people have different issues. I've heard so many elegant speakers come before me. We're in this business because of compassion. And we're all passionate. Because why? We take care of the vulnerable. We all hate fraud. Trust me, we hate it. You need somebody in charge of it who can deal with it. DHS is the wrong entity. I've watched situations over years of bad companies, bad players happening. We don't have anywhere to report it. There used to be a gentleman at the state of Minnesota named Tom Newman, had a good fraud department. You call him up, you send it, you look up, that person's gone out of the program. That staff, no more UMPI number for that PCA. Now you report it, they just move to a different company. Nobody cares. These are very hard times. Amongst this situation, UCare folds. UCare was a very large payer, you all know that. Just let it go, nobody cares. That's a financial burden. Now we're getting these audits, the quarterly audits, holding money back. Now you're getting the prepayment review, holding money back. At what point do we just give up and make jelly beans and t-shirts? It's 101. These people are, someone mentioned up here that the hospitals will be inundated. Not today, not tomorrow, but when they're not getting their care, they're going somewhere. And you guys already had to bill out HCMC for how much money? They're not gonna handle it. Our industry takes care of people for a much cheaper cost. After our years of service, I can only say this is a betrayal. I know you guys are elected and gals are elected, so I appreciate your service. I've been elected. It's a tough thing. I've emailed people. I've tried to go to federal people. They won't answer me back. They won't come back to me and say, hey, what's your concern? What can I help? I've tried to talk in the federal level. This is like you put two older brothers in a room to fight, and the rest of it got thrown over the board on the ship with no life jackets, just trying to defend what it is. I have other companies trying to call my nurses. Oh, I heard you guys aren't licensed. Come work for us. I got clients, what to do. We have, as of July 1st, started putting our mental health patients on hold. We can't service them. Not the ones with MA. Years ago, 6 months ago, I would have said, let's go to a two-tier system, Medicaid, Medicare. I have to deal with two payers only. Now, I turn around and say, let's get rid of the Medicaid, MA, and let's go to all HMOs, even though I hate them. But let's go to the HMO system because they can manage things better. My solution for this, revalidate everybody right now, then go back and slowly make them good. We are not the fraud providers. Find them. They probably quit within 2 years. Because why? You have to be recertified every 3. We just had our home care license come out. 3 people spent a week in our office in December. A week, seeing clients, seeing staff, knowing we were a real company. We just had our substance use program. 3 people, again, for a week in our office in March. They know we're real. But we get lumped inside of being a terrible company. We might as well just be the ones that the auditor came in and said, her last visit was a place with just sheetrock on the walls. Plastic. It's still under construction, nobody's there. We are considered the same as that company. Senator Hoffman, I appreciate your time. Distinguished elected officials, I appreciate your time, and the ones that aren't here, that are by Zoom. You got a lot on your plate, but DHS is a problem, and they're the wrong people to find fraud. OIG, also wrong people to find fraud. You allow them to go back to DHS and overturning decision where somebody actually went to court and won. So that whole process there is a backwards position. I don't know what the answer is. I don't say I'm for hire, but I'm sure plenty of us providers could show you where the fraud is. You just need to listen. Thank you. Grazie mille.
Thanks, Mark. Last two, Ken Bentz from ARM, and then Paul Verrett. You and Luella, are you both coming up? So let's get the 3. Go ahead, Ken. We'll get the 2 folks from the counties here. Thank you, people, for having patience. I started to have a little anxiety over the clock, but this is really important stuff, so I appreciate everybody for hanging in there. And with that, Mr. Bentz.
Thank you, and good afternoon. Chair Hoffman, Chair Noor, Vice Chair Gilman, and committee members from both parties, both bodies. For the record, my name is Ken Bentz. I'm the Director of Research, Analysis, and Policy at ARM. And rather than repeat what you've heard directly from providers, there's a few highlights that I want to make on some general concerns of ours. Our providers still have serious concerns about this process, and our hardworking, honest organizations feel that their ability to provide care is being threatened. I want to acknowledge that we have had some productive discussions with DHS, but the issue around provider communications is still one that we are concerned about. Providers are having a hard time getting questions answered, getting through to the Provider Resource Center, and being able to find out what is missing from the documents that they have submitted so that they can get their appeal completed and get their license back and going. Continuity of care, of course, is a major concern, and so we know that there are providers out there who have appealed who still have not had their billing reinstated. And Commissioner Connolly mentioned earlier that for those who did have billing reinstated, there is now a fix to be able to allow them to get service authorizations approved and renewed. We have not seen any communications on that yet, and so I'm not sure that providers have experienced that or are aware of that. And so being able to bill for all the people they're supporting is crucial, because right now they're providing services for many people for whom they can't get paid. A couple other things also, our providers are concerned about the continued barriers in making payroll and getting financing, because as Representative Zalesnikar mentioned earlier, lenders are less willing to extend bridge financing or are putting rates much higher because these are considered high-risk providers now. Because they are seen as less stable, they're having increased turnover, and you already know about all the workforce crisis that's happening in this sector, and this is making it worse. And then also, as you know, emergency departments and hospitals then become the backstop when residential staffing collapses. That puts more burdens on counties and case managers, who then have to scramble and find placements for these individuals on the whole continuity of care issue, and we want to try to avoid that. And the last thing is, as has been mentioned earlier, just the perception in the public that these thousands of providers who are disenrolled and are still in an appeals process, and the public's perception is were disenrolled because they were fraudulent and committing fraud. And in the vast majority of cases, that is not the case. We are concerned about the providers who are in the appeals process ultimately getting their records cleared, because in the first month since May 31st, we've only seen just over 300 appeals completed. And so we think the pace of this may take a very long time. So with that, I will allow the next speaker to speak, and we thank you for your attention today.
Thank you, Mr. Bentz. Paul.
Chair Hoffman, Chair Noor, members of the committee, thank you so much for this opportunity to testify. My name is Paul Verrett. I'm testifying on behalf of the Minnesota Association of County Social Service Administrators. And I want to be clear that we're testifying in the spirit of constant systems improvement, a value we all share. And I also want to have a particular focus on continuity of care from the county level. And then I also have with me Luella Coffer from Hennepin County, who can speak on an individual county level and is a subject matter expert. MACSA and the Association of Minnesota Counties, we were notified at the beginning of the revalidation process and also a few days before the 5/31 deadline that there would be a larger proportion of providers who would be disenrolled than expected. After those communications went out, we started working with providers from the county and started making our own preparations for continuity of care. Initially, the resources we had available, there were no new resources, and as you know, there is no single comprehensive database of providers and openings that we could use to match people quickly to alternative care. County staff might have more experience than some individuals seeking care, but we essentially depend on local experience and the ingenuity of our staff. After that, DHS began providing the weekly update meetings for the counties and tribes, and we started receiving lists of people and providers who were potentially impacted by disenrollment and the appeals process. DHS staff were also available to county staff. Unfortunately, during that time, we were also receiving reports from providers about not being able to get calls back about their recertification and revalidation processes. And I want to go on to some very specific points that might be things that we need to pay attention to immediately about continuity of care. I mentioned before that we were receiving weekly lists. We receive lists of people who are potentially impacted. The lists are very difficult to use. They're Excel lists that come through a secure source with the state. And in the case of one medium-sized county, they had the last week's list had more than 7,000 lines on it. And some of the things that are difficult result in us not being able to triage the list. So county staff have to go through the list. County staff need to know more about the statuses of providers on those lists. And we also need to be able to easily see who should be worked with first, which providers are in the most danger of closing, and equally important, which people are in danger of losing residential services, and then anything else we can use to find high acuity people that we serve. So again, those lists, we're very grateful that we're provided with them, but we need help being able to triage people on the list. Additionally, and a lot of this is just anecdotal, we hear a lot of that the status of the providers, when we hear directly from them, it's not always the same as what's on the list, and we understand that that might have to do with just the speed of updating information. The impact of all this is that we are basically at equal risk of trying to help people who are not in as much danger of getting care as those who are in the highest danger. So we need to be we need ways that we can actually triage that. I just wanted to repeat that. While we haven't formally surveyed our members about this, we check in regularly with the counties to see if they're aware of clients losing care. So far, it sounds like it's a smaller amount, but we think from what we've heard from providers that people are going to soon, during the appeals process, if it takes too long, they'll reach the limits of what they can do with their cash reserves if payment is interrupted or any other issues carry on. So we're not hearing of very many losses, but we know that this could change if there's any problems. Thank you again for the opportunity to provide the testimony on this subject, and now I'll turn over to Luella Coffer from Hennepin County.
Thank you. Luella, welcome.
Good afternoon. Thank you, Chair Hoffman, Chair Noor, and members of the committee. I'm Luella Coffer. I'm the Senior Department Administrator for Access, Aging, and Disability Services at Hennepin County, and I'm also one of the co-chairs for MAX's Adult Services Committee. I'm here to speak today a little bit about our county's experiences. It's a complicated, confusing time. The county goal is the same as everyone else's here, to support people well and to ensure they can receive the services to meet their assessed needs. We're partnering with DHS and providers to ensure we have the information that we need in order to support case managers to meet the needs of the people they're serving. Right now, our leadership in our county is focusing on getting clarity where needed and planning in the most critical areas. Thankfully, we have been able to leverage some processes we've already had in place, including communication pathways with contracted and county case managers and a provider response team. However, the scale and magnitude of what's going on has created tremendous pressure, even for a county who has those kinds of resources. As you've heard today, currently our county receives the 2 weekly lists. We are very thankful for information. Operating without that information was even harder. But those lists, they have some limitations, as we've been hearing. The lists are intended for planning. So we recognize a provider's status may have changed. These things are being updated by the hour. Also, as you can imagine, the list of people who could potentially be affected by a provider's termination is lengthy in a county of our size. So we're balancing ensuring continuity of care for the people we're supporting with providing accurate information and direction to all of our case managers. We've focused our initial efforts on understanding the current situation for those people served by waiver providers who have a disenrollment termination final status and a provider not yet appealed status. That involves talking directly with the provider and getting clarity from DHS if needed on that provider status. In fact, my team was meeting this afternoon with DHS staff to get clarity on some specific provider records. We're also calling all waivered services providers. We're crossing our information that we gather from them with what we're understanding from the DHS lists, focusing first on residential providers and crisis respite providers. Related to continuity of care, when a case manager needs to support finding a new provider, it means cold calling from provider lists or utilizing their network. There aren't statewide lists, as Paul was mentioning, of providers available who we know will accept new people. So this is all a huge undertaking by itself, and really there's a cumulative effect, since provider revalidation, as we all know, isn't the only thing happening right now. For when supporting an individual person, to our case managers, it may not be clear what could potentially be affecting their continuity of care. So we in our county and as leadership, we're working to act quickly, but with accurate information. Thank you for your time and the opportunity to speak today.
Luella, I'm so glad that counties, that you came here. Because that's, you know, we talk about where services go. You know, and ultimately the lead agency in this case is always the county. So I appreciate your feedback and thank you for being here. And thank you to everybody for being here today. I want to thank Commissioner Connolly, again, your willingness to answer some really difficult questions because that's what we want. I want to thank the providers, advocates, and individuals and families who shared their experience. This is going to be my last statement, Jordan, but if you, I really need to get going because we've went beyond what we're doing. So I was going to adjourn us, but if you have a couple of comments you want to make, go ahead. I see your hand is up.
Thank you, Mr. Chair, and I appreciate this hearing today and getting the update from the Department of Human Services and also hearing from providers around their experiences. And I think we have a lot of work to do. And I hope that the conversation over the interim on this issue continues to make sure that we're protecting Minnesota taxpayers while also ensuring that Minnesotans who need these services get these services. Mr. Chair, I had one question before we adjourn today. You had mentioned that you were waiting on something to have the Optum report released, and just wanted to see if you could clarify what we're waiting on for that Optum report to be released to members of the Senate Human Services Committee.
I had thought, Jordan, that I had to sign a piece of paper requesting it, but I'll tell you this, Schumacher, his final duty as a chair was to put in that request on behalf of the chairs here and you, and so that apparently is in the works. We should. I don't know when we'll be getting that, but I was given that update. I thought I was waiting on a piece of paper from you, but ignore that. So there you go. But I think Schumacher took care of everybody here. Is that correct? My understanding too on that, Senator or Representative Newer.
Thank you, Mr. Chair. I think there was an email request that was sent to the commissioner requesting a follow-up because of the legislation that we passed in requiring that the information stays within the Human Services committee. So at least I think that request was sent in.
Thank you. That's correct. So thank you. To that, members, I just want to, today's hearing reinforced some important realities, and I was jotting these down, is that program integrity and access to care are not competing priorities. They're complementary responsibilities. Minnesotans deserve a Medicaid program that protects our taxpayer dollars, but it ensures that qualified providers can deliver care without unnecessary barriers. This hearing also demonstrated the tremendous pressure that was placed both on the department and the providers as we worked to meet those aggressive expectations that were in front of us. That context matters. We also heard clearly that communication, consistency, and predictability matter. Providers need clear expectations. They need timely responses. They need confidence that when they follow the rules, they can continue serving Minnesotans without unnecessary interruptions. There are still, providers are still seeking answers. There are individuals and families concerned about continuity of services. There are still opportunities to improve the communication, streamline those administrative processes, and rebuild confidence, and that work must continue. The role of this committee is not to manage the department. Our role specifically is oversight. I want to acknowledge everybody here for being part of that. I also want to acknowledge it's something that is easy to overlook, that behind every policy discussion are real people. In every enrollment decision, every payment delay, every processing backlog has the potential to affect somebody's ability to receive care, remain in their home, and continue to live independently. Those individuals must remain the center of every decision we make. I appreciate the respectful and thoughtful discussions today, and this is how good government works. We ask questions, we listen, we learn, and then we act. But at the end of the day, success is not measured by how many applications were processed or how many requirements were met. Success is measured by whether Minnesotans' most vulnerable residents continue to receive the services they need from a provider network that is strong, stable, and trusted. So I want to thank everybody who contributed today. We are adjourned.